So I'm speaking today with Natalie and Leah from Aspire Emergency Services about some amazing resources that are available for everyone in Quincy and across the Commonwealth. I hope you enjoy our conversation. Natalie, Leah, thank you so much for joining me to talk about Aspire Emergency Services today. It's kind of a serious topic we're going to be talking about, and I'm really grateful. We've only been talking for a few minutes before we started turning on the recording, but I can tell that you're both very approachable people who, are not screaming panic. This isn't going to be a doom and gloom conversation. So help me understand well, let's first say hello and let people know who you are. So Leah, tell me a little bit about yourself and how you came to be here today.
Thank you so much for having us. It's a great opportunity to be able to share, a little bit about what Natalie and I do for the Emergency Services Program and for the community with some of your listeners. So thanks for having us.
Oh, thank you for joining me. Natalie, would you like to say a couple of opening words before we dive into emergency services and what that means?
Emergency services is a very broad service, and I'm so happy to speak with you guys about it today because I think that there can be a lot of questions or sometimes apprehension with giving us a call, and I really pride myself on being able to explain the services, what is available for the community, and how you can access us.
Well, thank you. I'm looking forward to exploring this, and I know I'm going to learn a lot in this conversation already because when I think of emergency service, I think I smell gas, I smell smoke, somebody's fallen and I can't figure out their legs at a weird angle. Those are obviously all emergencies, but I don't think those are the kind of emergencies that you are really addressing.
You're absolutely right. Well, sometimes, but it really just depends on what the intervention is that the person is looking for. So typically our emergency services team specializes in mental health and substance use disorder emergencies. But that it doesn't have to be gauged necessarily by the individual. Sometimes we get calls from people who are looking for an additional consult. We get calls from maybe a mother who's concerned about her son who's been withdrawn and in his room. Maybe it's a family member who says that, I just heard that Johnny has been feeling pretty down on himself and they want someone to talk to. We're 24-hour, 7 days a week services. So rain, sleet, snow, Christmas, New Year's, holidays, we're available. And we want individuals to feel comfortable coming to us, talking to us, and just saying, hey, I need someone to speak to. Who can I talk to? We have people that are readily available.
So people can call, and we can put the number on the screen and share it with folks so they know the number to call. Is it somebody who can provide the help that picks up the phone all the time, or they're leaving a message with a service that then pages somebody and they call them back? How does it actually work when they call?
Great question. So we have triage clinicians that are available. Those are the individuals that do the initial phone screen. So they're going to ask the standard safety questions. Is the person in imminent risk at this moment? What does your emergency look like? How can we intervene? Where's the best location for us to intervene? Our triage clinicians are typically the individuals that decide, should we go to someone's home to evaluate them? Would it be safer for the person to come on site to our 460 Quincy Avenue setting? Is it going to be a safer option to potentially have somebody have an emergent intervention where we are able to enlist whatever emergency personnel that we need at that time? It really just depends, but the person that answers the phone is usually the first line, we always say, and they're the ones that do the initial screening. We never have an answering service. We don't even have an answering service built within our system because you're going to get a live person every single time you speak to us.
And just to add to that, if I can add to that, when we're talking about the term emergency and we're looking at what that looks like, one thing we feel really firmly about and that we stand by is that an emergency looks vastly different for every single individual, whether it be
really good point. Yeah.
What an emergency looks like for me, for you, for Natalie, or for any other person picking up a phone to call us. And I think for any of us, there's hesitation to call and say, I'm in an emergent situation. And I think
I want to think we got this under control. We've got this.
Yeah.
I don't want to admit that there's something that's bigger that I can't handle because I got pride. I think we're all like that.
Exactly. And we don't want people to feel that they have to be the one to gauge that. So although it's called an emergency services team, Sometimes if you're just feeling a little blue and you want to give us a call, we're the individuals to call. It doesn't have to be gauged as an emergency, as, you know, everything is coming down around me. Someone has to be at rock bottom. We don't want people to feel like they have to be the ones to gauge that. We just want to encourage people that if you feel that you may be in some sort of psychiatric need, or, you know, substance use need, we want you to call us first.
So I'm sure some people, besides just having their own pride kind of in the way of asking for help, there's going to be a fear that, like, you know, there is going to be some kind of response, and all of a sudden, you know, a car is going to show up with sirens blaring. It's going to tell their neighbors that we got somebody who's got a problem here, or you know, they're going to be taken away from their home, or they're not going to be able to feed their cat in the morning. I mean, there's all these concerns. How do you help people get over those fears?
So usually when we speak with individuals, we never jump straight to that conclusion, because with emergency services, it's never about sending someone or removing someone from their home initially. We pride ourselves more on being able to create better lines of communication for you, of services, of providers, of intervention. We almost never want to remove anyone from their home. When we do our initial evaluation, we're trying to gauge what is going to be the least restrictive option for this person at this time. And we do a lot of education prior to the evaluation, just discussing what the evaluation will look like, what does this intervention entail, and what is the overall outcome? What would you like to see happen? And so it doesn't feel so much as a drilling down with the who, the what, the when, the where, the how, but it's more motivational interviewing to discern what would be the best needs to serve this individual. And most importantly, why now? What's going on at this moment that led you to give us a call? And we do quite a bit of risk assessment in a lot of that, but we are mental health providers. So we are very well aware that not everything is linear. Everything is on a spectrum. And overall safety is our priority. And so when we're assessing someone, we're not going to be super reactive if we hear something that, say, you know, maybe a mom or aunt or, you know, a sister heard that would make them clutch their pearls. You know, we're a lot more in depth in our assessments than that.
One of our initiatives, I mean, so what we want to do is provide evidence-based care for behavioral health in a community-based setting. Our initiative is to do everything we can to provide support proactively instead of reactively, and to work with a patient and provide voice and choice, we say, to a child, to a family, to an individual, in saying, to the best of our ability, you know, within the scope of safety, we want to work with, you know, we're not the experts here. You know, the folks we work with are the experts, and we want to help navigate, you know, every resources that we can, and really provide linkages to community-based supports, integration throughout the community, and, you know, everything we can do to work with a family and their natural supports to keep someone safe, we want to be able to do. So that's always our primary goal. And again, safety, we have to work within the scope of safety, but our goal is to, because we understand, you know, research, you know, across the board says community-based treatment is really how someone can really be successful in seeing improvements in their mental health, in their substance use disorder. And we want to promote that as much as we possibly can.
And I think what that means, when you say community-based treatment, when I think of that, it means that you know, a treatment that's not extracting folks and saying, okay, we're going to fix you and then return you to your home environment. It's
Exactly.
We're going to do this in place. We're going to say, this is our life, this is your life, and this is how you're going to deal in life with these challenges.
Right.
Yeah.
And that intervention doesn't always look the same every single time. And, you know, sometimes sometimes there can be a lot of stigma around, well, we have to, once you come in to do X, Y has to happen, but it doesn't have to. And we have great partnerships with a lot of local community based settings that can provide interventions, even our own within our Aspire umbrella, to provide services and get them quite quickly for individuals who may need it.
So I'm sure for a lot of folks, and this sounds like a really awesome service, not everybody has, you know, bottomless pockets. And this sounds like something that you could only get if you had a whole lot of money and can afford like massive medical bills. how do you address the economic fear that some people may have who say, this is great, but I'm not sure if it's for me because I can't afford it.
So unlike most other crisis teams, we are an insurance blind crisis team. And with that said, that means that anybody can come here, uninsured, a little bit of insurance, not so great insurance, commercial insurances. We don't want people to feel that they have to be insured to come. We are an emergent service, and with that being an emergent service, we provide care to everyone that comes through our door.
That is awesome. That is really, thank you. You mentioned having a lot of different community resources that you connect people with. First, I'd like to understand how the two of you work together, because I know, Natalie, you're really working in the community. Leah, you're overseeing more in the hospital setting. So there's a continuum there. So I don't know if you'd like to say a little bit more about your both roles, and then the resources, let's expand. Once we talk about that, we can talk about the other resources maybe that you can help people navigate.
Yeah, so Natalie and I, she's had to put up with me for 5 years now as a colleague, which I'm sure she loves every single day. But we've had a pretty great opportunity to, like Natalie mentioned earlier, the emergency services has really expanded greatly over the past even 5 years since we've been working alongside one another. And I know that there's a lot of work being done across the state, across the country, and one of those things that we're seeing success is integrated care. So about just over a year ago now, my role kind of transitioned to be a part of an embedded team within South Shore Hospital and South Shore Health, and looking at how can we integrate behavioral health into an existing hospital system to really meet the needs of the patients who are currently presenting through the emergency room, or who we're seeing in some other hospital-based settings. So what we do now is we have a 24/7 embedded crisis team or emergency services team within the hospital system that we work directly alongside the community team with. So if someone does present to the ED for something related to psychiatric illness or substance use disorders, there are certainly times where that's needed, right? When there is a medical emergency, or when someone's, perhaps really needs some medical management for withdrawal symptoms or for an active substance use disorder. So we certainly would never deter someone from presenting to the emergency room or calling 911 for a true medical emergency. But now that, while we're within the emergency room, we see a great opportunity to provide a lot of psychoeducation to the folks who come through the door, and saying, next time, if you feel like you need some support, we're here. Our community team is here. We can provide it's the same exact team, the same exact training, the same exact level of education that you would get coming through the emergency room for the same crisis emergency services evaluation as you would get in the community. And Natalie and I work alongside each other day to day, overseeing the two kind of branches of the team, but overall we are one emergency services program. So there is a huge opportunity for us to provide a lot of education in saying, coming through the emergency room, if there's, for something that we may be able to manage in the community, may take 4, 5, 6, 7, 8 hours before you're able to meet with a behavioral health clinician, as opposed to maybe calling our 24-hour number and saying, hey, I'm not sure, is this something I need to go to the emergency room for? Is this something I could be seen in the community for? We can help you navigate those things. But instead of that extensive several-hour wait time, we may be able to have you either come to you or have you come to us and be seen within an hour. And I think it's important that I think it's our job to make sure that we're educating the community on those resources and those options. It's important for folks to be informed because it's difficult enough, I think, to kind of admit that maybe there's a need to seek out some support for behavioral health. And I think if you can do it in a more private setting, such as in your own home or in our Quincy office on 460 Quincy Ave, I think it may encourage folks to reach out sooner rather than waiting till there are no other options and really in that acute, severe, place of emotional distress. But again, I want to reiterate, when there is a medical emergency, we would never deter or discourage someone from calling 911 or presenting through the emergency room.
Oh, absolutely. Yeah, this is definitely not a substitute. If you're bleeding out, stop the bleeding before anything else.
Absolutely. And then just to kind of add a little bit to the piece of integration, not just for, the emergent services that we are able to kind of collaborate with the hospital-based setting, but there are a lot of programs within the hospital-based system that we refer a lot of people to that can be done on an outpatient basis. So with Leah being in the role that she's in at South Shore Hospital, we can work together with providing better collaborative, say, substance use disorder services, maybe through the Bridge Clinic at South Shore Hospital, or if someone is, seeking perinatal services, we can refer someone to the hospital-based setting for that. And with Leah and I working closely together, we're able to liaise that and see the continuity of care follow through at that point. So when I look at the advantages of how integration really works within the setting, I think that we do a really good job, tooting our own horns, about how we can provide better continuity of care and giving people the longevity of services that they need. Because as you stated earlier, Clayton, it's a lot different than just sending someone somewhere, but then, sending them back out later. We want people to have services and providers that are going to last with them throughout the lifespan, not just a week or 2 weeks or so.
And to add to that, if I can, I think what Natalie just highlighted is highlighted just a few programs that Aspire and South Shore work alongside each other in, such as the perinatal program and the Bridge Clinic program. With it, that Aspire has clinicians working within the South Shore Health System substance use disorder treatment program. But I think it's important to say that there are so many different programs out there. What we can say that we try to be the experts or as close as we possibly can be is understanding the resources. If you go online and you try to say, what are my symptoms? What can I do from here?
You can scare yourself going down that hole.
Yeah. Don't Google.
This is pre-COVID times. I get a runny nose and all of a sudden I have, a full respiratory infection. We don't want people to go down that road, and just give us a call and let us guide you through the next steps.
That is a great resource. And I really hope that we can help everybody understand, just if that's the only thing they come away with this, that's awesome. You mentioned COVID times.
Yeah.
It's changed. Obviously, we could have had a lot of everything we've talked about. If you were providing it a year ago, we'd be having this exact same conversation, but we are in a different era right now. How has COVID been infecting? How has COVID been affecting? Maybe it's infecting as well. Hopefully not. But how has it been affecting your ability to provide service and help people navigate with masks and distancing and everything?
A couple things. I think what we were seeing initially was that, folks, when the pandemic first hit, we were seeing actually a significant decline in the number of folks seeking support for behavioral health in the hospital and in the community. But the folks we were seeing were really acute and really severe symptomology at that point. But then we started to see policy changes and opportunities for us to really reach folks outside of an emergency room setting and in a really innovative way. Telehealth is, imagine what Natalie was going to kind of lead to, and I want to kind of pass that off to you. But we are now able to be more accessible than ever to patients in the emergency room, and even more so in a community when we're working with folks around the community, families, individuals seeking support. We can use something called telehealth, which I'll let Natalie kind of dive into a little bit more on the community side of things.
Yes, so to kind of add to that, and I wanted to start with that.
I know we finish each other's sentences sometimes.
The positive aspects of COVID in some sense, that, our outreach is a lot more versatile than it once had been. Prior to COVID, we only provided on-site community-based setting. And hospital, of course, but now we're able to intervene with individuals right in their home, in the safety of their own homes, and be able to communicate with them, such as we're doing right now during this interview. And a lot of people have found that to be really advantageous for their lifestyles, whether it be, maybe I just came from out of town and I need to quarantine for 14 days, but I feel like I really need this intervention. Or, I have other children here and I can't bring my 15-year-old, I can't leave my 5-year-old to bring my 15-year-old into a crisis evaluation. So telehealth has been very pivotal in the care that we provide. And we've gotten a lot of great feedback from our clients that state that the intervention of telehealth alone has been monumental for them in being able and how they're able to access crisis services.
And just to describe what we mean by telehealth a little bit more, for anyone with a smart device, for anyone with internet access, for anyone with a web camera, we can literally pick up our laptops just like we're doing now and interface over Zoom.
So we've talked about telehealth. Everybody knows about COVID. I've learned a lot about emergency services today. What is this crisis stabilization or community crisis stabilization? What does that mean?
Our community crisis stabilization unit is for adults over the age of 18, preferably not school age 18, where we provide an 8-bed voluntary service where people come on site to our center. The 8 beds are actually right across the hall from the emergency services team, and they have a clinical coordinator who is a master's level clinician who provides therapy and group supports, as well as a nurse manager and an RN or an LPN to do medication administration, and a mental health worker to provide ongoing support. People come there, they stay there overnight, and the typical length of stay can be anywhere between 5 to 7 days.
Mm-hmm. So if you're having some kind of intense episode, it's a place where you can find relief.
And it's a great diversion from, I would like to say, like a psychiatric inpatient setting. Mm-hmm. This is a much more home-based like setting, feels very like less institutionalized. And I think that the care that is provided there is excellent. We also have a psychiatric nurse practitioner who does medication prescribing for individuals that come to the CCS.
So is it entirely voluntary, or do people get sectioned and come there as well?
It is entirely voluntary. And if someone is meeting Section 12 criteria, then chances are high they have to go to a higher level of care. However, we have had instances where someone may have been slated maybe for a Section 12, but then after intervention, they are able to be stepped down to our crisis stabilization unit.
So one last question, and then we'll see if there's anything else that we missed that you want to touch on. I know that emergency services is providing awesome resources now. In Quincy, we're seeing some radical changes in the health resources that are available. We've got an emergency room that's closing. I don't even know the latest state of things, but I know it's in flux, and I know that some services are disappearing from the community. How is that impacting your ability to provide services? And what
I'd like to say that, in some ways where the service for the community, yes, from a medical standpoint, I do think that with the closing of Quincy Emergency Department on November 1st, it will have an impact on the community. However, as far as mental health services, we're still here. We're still available. And I think that this provides a great opportunity to have people come on site to our emergency services team to get your psychiatric interventions met there. Because as we stated earlier, an emergency room setting or a hospital-based setting is not necessary to get the support that you need for whatever psychiatric substance use disorder intervention that you may be requiring. That's just a knock on our door here at 460 and coming right in.
I'm sure we would all like to avoid emergency room visits if we can. So
absolutely, especially
against all the awesome people working there, but yes.
Right. Especially with the times that we're in, we want to encourage people to not go to the emergency department because, you go in for a psychiatric crisis and, who knows what you come out with.
And it can take 4 to 6 hours rather than
right. And the length of stay is ridiculous. It's absolutely ridiculous. Yeah. So we want to take this opportunity with the Quincy Emergency Department closing to have people come on site to us. And so I'm taking this notice I'm framing it as an opportunity. So because I never want the community to feel that there's a service that is lost to them.
Okay, great. Is there anything else you'd like to leave folks knowing? Did we miss anything here as we've been talking about this amazing, really inspiring work that you're doing?
I think Natalie and I are very passionate about the work we do, and I think we work with a tremendous team of clinicians, of peer specialists, family partners, you name it. And I think we've grown so much as a program within the agency and across the state for ESP programs and crisis programs everywhere. What I want to mention is that what we have here at Aspire, for the towns that that we work with, there's a team for every single town in the Commonwealth of Massachusetts that does similar work that we do. And I think it's really important that if you or someone you know is really struggling with a psychiatric illness or substance use disorders and not sure where to turn, pick up the phone, give us a call, come walk into our building and just talk with us. And we want to do everything we can to provide that education, that support, and those resources in a really proactive manner. So we certainly encourage you to do that, particularly right now. There's some really trying times, and there's some, we're here for you, and we're here for your family.
That is just such an amazing resource to know that that you're just a phone call away. Do you have are there other ways to reach out to you? People can obviously stop by and visit. Is there chat or online? I mean, we talked about telehealth. Can people just kind of log into an open chat room or something? I don't know the other avenues.
At this current juncture, the best way to get a hold of us is to give us a call.
Okay. And then you'll set up everything from there.
And then we will set up everything from there. Again, it's a 24-hour service. And to kind of piggyback on something that Leah said, no matter where you are in the Commonwealth, you can have access to this team.
Everybody can call you. It doesn't matter if they're sitting in Quincy, or over in Braintree, or they're out in Northampton.
Right. And if someone is able to even get in contact with us via telehealth, you can live in the Cape. I mean, we have services that are available that we could help liaise individuals to, and even in some ways connect them to their local emergency services team for future interventions. But as stated earlier, we are an insurance blind, so we want people to come as they are, whatever they have, not to feel like they have to hit a series of check boxes to be able to get this service. This service is available to everyone.
Well, I'm so glad to help let people know that the service is available. I can't imagine how I have wonders about the logistics and how you keep from being overwhelmed. I hope you're taking care of yourselves and the people working with you, because this just sounds amazing and could be really exhausting and hard work. So I just wanted to let you know that I appreciate it, and the community, I'm sure, really appreciates everything that you're doing. So the more we can do to help people appreciate these services and know that they're there for them, it's just a great work. Thank you.
Thank you for having us.
So much. Really appreciate the time.
I hope you've enjoyed my conversation just now with Leah and Natalie from Aspire Emergency Services. I'm really impressed by the work that they're doing and the level of resources that they are making available to me, to you, to everyone in the Commonwealth. They're just a phone call away. So if you think you may need some help, please give them a call. Thanks.